Welcome to my podcast. Today I'm going to talk about another case that you might face, and you just need to have quick thinking and explore what might be the reason for the sudden attack. So after you introduce yourself, double check the patient name, date of birth. The patient might present in the clinical setting or might present to the A&E if they are panicking and really distressed and great distraught. So the patient is young. It's actually a student who had presented with sudden loss in one eye. He's otherwise fit and well. And he would say that he linked that to a bout of cough. And in the last few weeks, he was diagnosed with pertussis and was treated for that with erythromycin. And even though he's recovering, he's still having, from now and then, occasional fitful cough. So he notes that the central vision is lost. However, the peripheral one, he still can see. He has given a history of migraine, but without aura, and he said that it's responding to the NSAID. He has no history of trauma or any other symptom. There's no similar family history in the family, and he had no issue with his eyes whatsoever previously. And the only medication he's taking is NSAID, and otherwise he's fit and well. I'm just studying, as I mentioned. So based on those kind of information you've been given or been asking to investigate what might be the reason for this, you need to build up your risk factor or your differential, take into consideration the age of the patient, who is still young, fit and well, as I mentioned. So you will just do quick observation for his vital signs, which seems to be okay. And then you will proceed systematic examination. So I might do a quick chest auscultation. I mean, of course, after you do the ABC, and maybe quick examination for the tummy. And then you will have a quick glance for the eyes. If he presented, of course, to the emergency eye hospital, that's what they're going to do. So they're going to investigate the eyes. So they're going to see the vision first, and then they will see a close examination for the eye. And proceeding to that, they're going to do fundoscopy. So the pupil was equal and reactive, and externally there is nothing to be seen. And under the slit lamp, the anterior chamber and the cornea, pupil, everything is fine. And in examining the back of the eye, it seems that there is hemorrhage in the retina under the hyaloid and the posterior pole of the eye. So take into consideration the symptom based on the risk factor here is obviously forceful coughing. And there is a condition called Valsalva retinopathy, which is a self-limiting benign retinal hemorrhage due to sudden increase of the intra-abdominal and intrathoracic pressure, which could disrupt the fragile perifovea capillary. We know that also sometimes with sudden cough or anything that raises the intrathoracic and intra-abdominal pressure, this will lead to subconjunctival hemorrhage as well, which is a benign situation as well. And there is other risk factor that you need to consider and differential. However, talking back to this case, it has been shown that there is other risk factor which could lead to hemorrhage in the back of the eye and sudden loss of the eye, of the vision. Like nowadays, we see a lot of people, whether it's men or women, the trend is for weight lifting, excessive weight lifting basically, vigorous exercise. The other factor is, as I say, in this condition, forceful coughing, and also it has been linked certain sexual activity, also in labor, balloon blowing, breath holding, habitual ear popping. So all of those are risk factor for this kind of condition. The other definition you need to think of, like we know in diabetes, which will cause, of course, proliferative diabetic retinopathy with new vascularization. And so it's pre-retinal hemorrhage, so I need to rule out if the patient has diabetes or if it's uncontrolled, if it's long-term diabetes. Also, if there is history of trauma, and also in another condition called with ARMD, which is macular degeneration. We know there is dry and wet, so that's one of the conditions. And also another condition can be hemorrhagic post-vitreous detachment, so that's another condition. However, other conditions can be rare, like ruptural retinal aneurysm or dyscrasia, blood dyscrasia. So in that condition, if you are in doubt about anything that you need to undertake for the underlying possible causes, you can do or run certain investigation like full blood count, blood glucose, inflammatory marker. And then you talk to the patient, explain what you see, what's the situation, and of course, ask the patient if they have their own thought. Like early on when I mentioned, the patient said that it has been linked to the cuff, so in that condition you ask it about the patient idea and thoughts and theory for this kind of condition. And the management, you need to agree with the patient moving forward in order for the patient to be happy and take management into consideration. So if it was a small one, you'll tell them that it's usually going to resolve by itself, self-limiting. You just arrange for a follow-up, like observant management. However, it's quite large and in central, obviously going to obscure their vision. The patient might be panicking. So you'll arrange for laser or surgical removal. And you will red flag them if condition did not improve, it's getting worse. If you're not feeling well in yourself, come back to us again within the surgery or the A&E. So I hope by that I talked you through one of the cases that you might face, you never know, either in the emergency or in the GP setting, and you take into consideration the risk I just told you about and how you manage moving forward. If you come across something like this and you would like to share, put me back in the comment and I will get back to you. And I see you in another podcast. Thank you.